Terrific. All right, well, thanks everybody for coming. So great to have everyone get together again. Happy to lead today's discussion on the use of prazosin for feline urethral obstructions. As always, let's make this as collaborative and interactive as possible. So anytime you have a question or a comment, go ahead, unmute your microphone, shout it out. Let's have some discussion here. If you don't have a microphone, feel free to write it in the chat, and I'll keep my eyes on that as well too. But let's go ahead and get everything started here. So let's start with a poll of the management. So let's start here. Do you prescribe prazosin or phenoxybenzamine if you don't have it? If you don't have prazosin, do you prescribe either one of those drugs, an alpha antagonist, to cats with urethral obstructions? And maybe if you're on the fence voting because you changed your mind a month ago, let's say what you did a month ago. All right, I'll give it another 5 seconds, and then I'll end the poll. Okay, so the majority, 56% of us, give phenoxybenzamine or prazosin to cats with urethral obstruction. Only 30% of us don't. Another 13% of us don't manage UOs while being hospitalized. That would be my position. I don't manage the UOs when they're here in the hospital. I see them if they have some complications, but otherwise I don't manage them. So in my hospital, it's our emergency service that are the ones that are managing. So very interesting. Let's kind of get into this study a little bit more. So the study we're going to be talking about today is this: prazosin administration increases the rate of recurrent urethral obstruction in cats, 288 cases. Now, before we dive into that, let's back it up. Let's talk about prazosin. Let's talk about urethral obstruction in cats, and let's just try to get a good framework for why we might be using this, how it could be helpful, how maybe it's not helpful. So if we look at there we go. Sorry, my computer froze for a second. If we look at the urethra of the cat, this is from a study published in 1999. This is the male feline urethra, looking at cross sections of it. The letters are representative of each of those slices through the urethra. And it's a black and white image because it's an older study, it's not in color, but I have labeled the location of smooth muscle and striated muscle for you. So if we start at the pre-prostatic urethra, it's really just the epithelium, the submucosa, 3 different layers of smooth muscle, then the peritoneum. So that is reflective of section A. Then when we get to the level of the prostate, there's a shift, much less smooth muscle, and then the striated muscle really becomes more predominant. Remember, cats don't have a true prostate gland. They have a more diffuse prostate that surrounds their urethra. That's section B. In the post-prostatic section, which would be C, we no longer have any smooth muscle. The striated muscle forms these kind of columns of muscle that once we get to the area of the bulbourethral glands, which is both D and F, the striated muscle actually works to surround those bulbourethral glands, both in the early portion and then in the later portion of that area, much more meatier striated muscle. And then we finally get to the distal urethra, which has just a very small band of striated muscle, and that's your urethralis muscle. That's there. So predominantly throughout the feline urethra, it's striated muscle. The smooth muscle is only present in the very proximal portion of the urethra, the pre-prostatic portion, and then very minimally in the prostatic urethra. The control of that smooth muscle is under the effects of the hypogastric nerve. That's supplying sympathetic innervation, and it's going to release norepinephrine to the alpha receptors, and that's going to constrict the sphincter mechanism, and it will interact with beta receptors on the bladder to relax the detrusor muscle. So that's our sympathetic tone. And again, that's norepi. These are the receptors that we're going to essentially be interfering with when we give prazosin or phenoxybenzamine. Just to review, the pelvic nerve, that's our parasympathetic innervation. That's releasing acetylcholine to the bladder to cause constriction. And then the pudendal nerve is our somatic innervation. That's acetylcholine to the urethralis muscle as well as the anal sphincter, and that gives us some additional contraction. So, knowing that we have a very small portion of smooth muscle under the control of the hypogastric nerve, what are the effects of prazosin and phenoxybenzamine at those sites? So here is a study. This is looking at the percent of maximal constriction of a control that we're seeing with the effects of prazosin given to this cat. These are all experimental studies. And you can see that essentially at different frequencies, so different intensities, different speed essentially of the hypogastric nerve stimulation. So there's an electrode in the hypogastric nerve. We can see that the administration of prazosin, 0.1 mg per kg. So for a 5 kg cat, that's going to be a 0.5 milligram. That's a pretty reasonable dose than what we use clinically. It impedes the constriction of the urethra compared to those cats that receive the control. So it does do something. This study did not look at phenoxybenzamine. There was a different study that looked at the effects of phenoxybenzamine. This one's a little bit different. They're measuring urethral diameter at various lengths from the tip of the penis. So the bigger the number, the more proximal it is. And it's a very busy table, but they evaluate, compared to a control, Valium, phenoxybenzamine, nifedipine, and xylazine. And we can see that phenoxybenzamine did reduce the urethral pressure. So this isn't talking about diameter, this is pressure. So in the previous slide, the difference in diameter would be dilation. This is actually going to be pressure, which is going to be an effect of that constriction. So the lower the pressure, the more dilation that's there. And it was only statistically significant at one point that the pressure of the urethra, 5 millimeters from the tip of the penis, which is probably mid-urethra, probably not certainly into the prostatic or the pre-prostatic urethra where smooth muscle lives. But that's the only site that was statistically significant compared to controls, where controls had about 80 millimeters of mercury of pressure or 80 centimeters of water, and with the administration of phenoxybenzamine, it was reduced to about 50. So here's your evidence, right? This is the evidence we have that phenoxybenzamine and prazosin might affect urethral tone. These experimental studies, that's really what we're going from. Just to give you an idea of how this type of study was done, this is a figure from that study. So all these cats were maybe minimally sedated, but they were restrained in a bag, and then they had this harness with their leg attached to it, so they had easy access to their urethra. Maybe or maybe not going to be able to be passed IACOC review boards as of today. Who knows? But that's the evidence we have, and there are a few more studies that are very similar that produced not disparaging results from what I've shown. So that's our evidence that prazosin and phenoxybenzamine potentially might do something, whether that is strong evidence or weak evidence. Let's actually talk about urethral obstructions and why do cats develop urethral obstructions. And certainly there are several different mechanisms for this. There's not one cause that will affect all cats. This was a study from 1969, which I thought was really interesting. And this is where they took urine from cats that had an urethral obstruction, and then they inserted it into the bladder of cats that weren't obstructed, and those cats developed urethral obstruction. Then when they took the urine and then they passed it through a filter and then gave it back into the bladder instilled it into the bladder of cats who are normal, it still ended up causing that obstruction. So this old paper suggested, well, maybe there's something in the urine that can be transmitted that's causing that. And very short study, they didn't really speculate on what that may or may not be. But it's an interesting thing and a concept that, as far as I'm aware of, has really not been repeated. There's been a fairly recent editorial that proposes that urinary androgens might be playing a role in urethral obstruction in cats, but androgen assays for cats are not widely available, so they gave a lot of theories, but there was not really evidence to back it up, and suggested that androgen testing become available so it could be tested further. So I didn't include that study in these rounds because I didn't think there was enough substance to really remark on. But going back to what has been proposed and really the things that we still talk about, this is from a paper that I forget if this was Joe came out with this in Old Vet Clinics of North America, or it might have been Jody and Carl Osborne. But anyways, it's citing the initial paper that it was pulled from in the figure legend there. But essentially, there's a paradigm where we could have inflammation, and that inflammation could be rarely infectious. We know that bacterial cystitis is a very rare cause of urethral obstruction in cats. There could be non-infectious inflammation that could increase the production of mucoprotein 1, otherwise known as TIMS, horsefall mucoprotein, other inflammatory proteins that will cause this gelatinous matrix, and that could occlude the male urethra. There could also be crystals, and those crystals could lead to small stones and then big stones, and obviously stones could cause an obstruction. And those crystals, especially when they are bigger than just a microscopic crystal, when they're starting to make that sandy debris, that could be incorporated into that matrix. And it's probably a combination for many cats of the matrix and some of those crystals to form that plug that can cause an obstruction. We can certainly have stones that can cause an obstruction. We can have strictures, we can have tumors that can do it, blood clots. There are other things that are there, but this is still probably the predominant mechanism that we worry about and we think we see in many cats that have an obstruction. I don't have to repeat to this crowd that we don't really consider crystalluria in itself a disease, but it could be a strategy in those cats with obstructive feline lower urinary tract disease, that if they're developing these plugs with a lot of crystalline material, maybe not, but maybe reducing that crystalline material might help minimize that risk of an obstruction. I think the plug is probably sufficient enough to do it on its own, but that is probably the only time we consider treating those crystals, especially when we're talking about struvite crystals, as many of them are in cats. So those are some of the big causes. Now, how frequently do we observe them? Surprisingly, we don't have a lot of studies that really talk about the etiology of urethral obstruction as it was presented. I certainly might have missed another paper or two. Certainly Dr. Osborne had published on this. Some of those papers are just not available, and I don't have them in my library. But even the more recent articles tend to cite these three as being the main papers that actually give a breakdown. So John Kruger's paper from 1991 showed that the majority of cats with an obstruction had a urethral plug. Only 12% had a stone, and 30 were these idiopathic that were just not sure. Dr. Barsanti's paper from 1996 showed a pretty equal distribution between plugs and idiopathic, And then Dr. Gerber's paper from 2008 showed the majority were idiopathic. Now, the definition of idiopathic is not well defined because we just fail to see a plug or a stone. And I do think that there could be a number of those patients that we consider idiopathic that did have a plug, but it wasn't palpated at the tip of the penis, and then throughout the course of catheterization, it was flushed back into the bladder, and you don't have that firm, palpable thing you can say, aha, this is causing the obstruction. But there's a sizable number. Could this be changing with time? There's 10, almost 20 years between these two papers. Could there be a temporal association between diets, between just our veterinary care? Maybe. No one's really looked at that specifically that I'm aware of. But we certainly recognize these three as the most common causes. Strictures were really only reported in that one manuscript, and most other studies that I'll mention from here on out kind of don't. They exclude patients that had strictures or presume that they did, and they don't explicitly say. But then there are some studies, this is a study that Gilad published, and this was a retrospective study, but the cause of the obstruction was not identified in any of the cats. And maybe that's a limitation of a retrospective record review, that you just don't have the clinicians that write, I found a stone, I flushed a plug back, and that could be the nature of retrospective studies. It could be that all those cats maybe were idiopathic, but that's not what they're saying. They're saying it wasn't identified. So many studies will just not go into what the etiology is. Now, despite that, this is Ed Cooper's review that he published a few years ago in JVEC, Controversies in the Management of Feline UO, and he cites here that some patients may have a functional obstruction secondary to urethral spasm and edema, and that might be by itself, or that might be secondary to stones or a mucus plug. And there's a lot of talk about this urethrospasm. So really trying to dig into what is the evidence that we have for urethral spasm in cats with urethral obstruction. We don't have much research at all. There's this one paper from 1995 that did perform urethral pressure profiling in, I believe it was 6 cats that had a urethral obstruction. And they found, and I highlighted it for you, and again, I apologize, I don't have access to this paper. I just know some of its context and I'm reading the abstract to you all, but it said that strikingly, results of this study suggest that urethral muscle spasm had a minor role in these cats. But despite that, this is 1995, this idea of spasm has really permeated the approach that many people have taken to the management of urethral obstruction. In response to one paper that retrospectively looked at risk factors for recurrence, where cats were given either phenoxybenzamine or prazosin, Drs. Lulich and Osborne wrote a letter, JABMA, with some comments and criticism saying that, to our knowledge, urethral spasms have never been documented in cats. And then they cite that paper I just had in the previous slide. Only one cat had increased urethral pressure profile, and that was high in the post-prostatic segment. And if you remember back to the early slide, the smooth muscle, what is potentially going to be able to be modified by our alpha antagonists, our prazosin and phenoxybenzamine. The smooth muscle only exists in the pre-prostatic and then a little bit within that prostatic urethra. So this one cat that had increased urethral pressure had it in the post-prostatic segment, which is not where any smooth muscle lives. So Drs. Lulich and Osborne had suggested that there's not really substantial evidence for this, and further study is needed to really say that this is a thing and cats should be treated with it. And then, like most letters to the editor in JABMA, the authors get a opportunity to respond, which they did, and they hypothesized that there might be a subset of cats that have an increased urethral tone. Okay, I think we can theorize that despite the fact that there's no evidence for it, there could be. I guess I personally wouldn't go so far to say that it's impossible that they could have urethrospasm. And sometimes it does appear, if I remember back from my internship days, that that penis is almost quivering, but is that skeletal muscle that's contracting that's not going to respond at all to the prazosin and phenoxybenzamine, or is it smooth muscle? Because certainly what you're seeing from the penis and if it's spasming, that's not smooth muscle. The smooth muscle is all going to be intrapelvic. Remember, pre-prostatic to prostatic urethra, and that is it. They also propose that the mechanism for recurrent obstruction may be different, and maybe cats with recurrent obstruction could develop spasm after the process of having a catheter in place. So, certainly a controversial aspect of whether urethral spasm is a thing or not. Despite the lack of evidence, the use of therapies to affect the potential for urethrospasm is widespread. And so this next slide lists, and I'm sure I've missed a couple, but I try to go back and pull most of the studies that looked at the risk of recurrence for urethral obstruction in cats. And the range goes down to 11%. You can see that 11% recurrence was actually reported in 3 different studies, and the highest was 43%, and that was specifically from Bernard's paper that showed the urethral plug population had that higher recurrence. The earliest one that I'm aware of is Dr. Beauvais' study, which showed 35%. But if you look at these papers, I went through and looked at what percent of these patients received some type of alpha antagonist. And so Galad's paper, almost 97% of patients, so pretty much all of them were treated with phenoxybenzamine. The Hetrick manuscript, we're going to get to that. We're going to talk about that in a little bit more. The Eisenberg manuscript, 90% were on prazosin or phenoxybenzamine. The Seitz paper, 99%, all but one cat received prazosin. The Nibby manuscript, 100% phenoxybenzamine. The Davidow paper, 100% prazosin. And we're going to get more into Erica Reinecke's paper and the Hansen manuscript as well, too. So many of these papers are retrospective. Some are prospective. We'll get into the prospective ones. But the use of phenoxybenzamine and prazosin has been there in the vast majority of all of the more modern studies. Anything after the year 2008, I think in Bernard's paper there was only one cat that received phenoxybenzamine. That was it. And I don't think any were treated in Dr. Beauvais' manuscript, but I similarly don't have that one. But it's permeated everything that has been reported. Pretty much all cats with urethral obstruction in our literature have received a type of alpha antagonist. So let's go through some of these studies that are looking at the risk factors before we get into our study of choice, because I think it's going to line up, and we're going to talk about some of these studies that are referenced in great detail. So this is the Eisenberg study. This came out in JABMA in 2013. This was a prospective study, and they were looking at risk factors that could have led to recurrent urethral obstruction in cats. And 90% of them were given either prazosin or phenoxybenzamine, and they did not identify that either one of those 2 drugs had an effect. But shorter duration of catheterization increased the risk of recurrence. That is statistically significant to me. That's not clinically significant. The mean duration is 24.5 versus 26.5 hours. I mean, there's so much overlap there. I don't think clinically that makes any significant factors for me. Old cats had a higher risk. And then in terms of preventing the risk, they did look at those owners that did follow through with the recommendation to increase water availability. And those cats that had extra water around, whether that was switching to canned food, giving them water fountains, adding water to their food, giving them more water bowls was really the only one. Adding water to their food did not turn out to be statistically significant, but the numbers were quite small. So this is a prospective study here. The Hetrick manuscript, which is the one specifically that Drs. Osborne and Lulich had written their letter about, was a retrospective study looking at, again, factors that could be associated with the rate of recurrence. And retrospective, 97% of the cats either received prazosin or phenoxybenzamine. The doses were completely uncontrolled, and it was as little as 0.25 mg of prazosin per cat twice a day, up to 1 mg per cat twice a day, and a couple cats had, I think, 0.5 mg per kg 3 times a day. So very uncontrolled, retrospective. They did not see an association between the duration of catheterization, giving antibiotics, NSAIDs, or pain relief medication. And they did see a lower recurrence rate in prazosin compared to phenoxybenzamine. Within 24-hour reobstruction, 7% versus 22%, and at 30 days, 18% versus 39%. They did see less obstruction with a smaller catheter, 3.5 French versus a 5 French. So looking at the table from that manuscript, this is the difference. And they show this at time periods. So 2004 through 2006, 2006 through 2010. And you can see that there was a dramatic change. That up to May of 2006, all cats that they received an alpha antagonist received phenoxybenzamine. After June 2006, all cats received prazosin. So there's a temporal component that could be another variable that could introduce other factors, where there are shifts in the diet approach, where there are other things that could happen with time. The other thing, too, is if you look at their pain relief medication, even though they didn't see it, the early time period, most of the cats didn't get any pain relief medication, but only 12% received buprenorphine, compared to the later time period, 82% received buprenorphine. So not a statistically different finding, but these time periods, these cats were treated differently. And I don't know if it's just prazosin and phenoxybenzamine that was the only factor that could lead to those difference in outcomes. Let's talk about some of the studies that are specifically looking at prazosin. So Erica Reinecke had a prospective study. It was placebo-controlled, double-blinded. This was a randomized study. Cats received either a 3.5 or a 5 French catheter. So there's one variable. One study did show that less reobstruction with the smaller one. They excluded cats with a stone that was larger than 2 millimeters via an ultrasound, and they did a power calculation, determined they would need to have 28 cats in order to detect a difference from a 50% recurrence of urethral obstruction, which is really high. That's higher than anything that's been published. I'm not sure where that number came from. They did not cite anything for that, and reduced it by an absolute value of 37.5, so down to 12.5%. That's a pretty dramatic reduction. And to have 80% power, they calculated they needed 28 cats per group. Their dose was 1/4 mg of prazosin per cat twice a day versus placebo. They did not specify at all when the catheter was supposed to be removed or when these cats were going to be discharged. That's not in the manuscript. So 28 cats per group was what was estimated from their power calculation. They didn't quite reach that. 20 cats got placebo, 27 given prazosin. It was not statistically significant, but more cats in the prazosin group, 70 versus 50 in the placebo, had the smaller catheter, which again, one study showed less association with recurrence. They did also show that the prazosin group were more likely to have had a previous episode of lower urinary tract disease, 44% of those versus only 10% of the placebo cats. So maybe these prazosin cats were already predisposed to getting recurrence and other lower urinary tract disease. That's potentially possible. But they did not show that the use of prazosin changed anything. At the 24-hour mark, only 2 cats given prazosin and 1 cat given a placebo reobstructed. At 1 month, only 2 more cats with placebo with prazosin and 2 more with placebo. And at 6 months' time, 37% of prazosin cats, 31% of placebo, not statistically different. And so this study did not show a difference with prazosin. Obviously, it was dramatically underpowered. They were predicting 50% of cats were going to have an obstruction. With placebo, they only saw 17. So their power to detect a difference was only 4%. And in order to have statistical power based upon their data, they would need to enroll about 1,150 cats in the prazosin group and over 750 cats in placebo. So very underpowered, but there was no improvement that was shown. We have a second prospective placebo-controlled randomized double-blinded trial. This time it was a little bit cleaner. This was all first-time UOs. All cats had the smaller 3.5 French catheter. They excluded cats with stones based upon a radiograph, which you might potentially miss some small stones on. They did a power calculation here, and they said with placebo, they're expecting a 30% recurrence. That's been reported in the literature. And then with prazosin, they were expecting a 4% recurrence. I have no idea where they got 4%. That would be the lowest rate that's ever been shown. And in order to have such a big difference that would be observed, they only needed 40 cats per group, which makes sense. When you're expecting a huge difference, you don't need a ton of cats. They used a different dose of prazosin than the previous study, 0.5 mg per cat twice a day versus placebo, and they had rules for when to pull the catheter. Had to be in for at least 24 hours, but no longer than 48 hours. And remember, power calculation, 40 cats per group. They ended up enrolling 28 cats that got placebo, 37 that got prazosin. Cats that received prazosin did have a shorter duration of catheterization, which again has been shown to increase the risk of recurrence, but it was again statistically significant, but clinically 24 versus 28 hours, it doesn't do much for me. Rate of recurrence, placebo 18% versus 30% in prazosin was still not significant, was not powered. Their post hoc power calculation was only 19%, and they would need 200 cats per group in order to show a difference. So that brings us to our current paper. So where we're at so far is we have, I think, minimal evidence that there is urethrospasm in cats, although it has not been adequately investigated for sure. Despite that, the use of prazosin or phenoxybenzamine is widespread and common in the management of urethral obstruction. The prospective studies failed to show improvement, but they were both very much underpowered. They used different doses, but they neither even showed that the prazosin group trended towards an improvement. In both of those studies, their recurrence rate was higher. It wasn't statistically significant, but it was higher than placebo. So that brings us to this study, which just was published in JAVMA a couple months ago. Prazosin administration increases the rate of UO in cats. This is out of Tufts. This study had 2 different parts. So again, 2 different parts to this study. The first one, the objective, was to evaluate, and this is the quote from the paper, evaluate a large number of cats with urethral obstruction that were treated with or without prazosin, determine the rate of recurrent obstruction during hospitalization within 14 days after discharge. Very different study design here. This is a multi-center, observational, retrospective cohort study. So they sent emails out on the ASVN and the ACVEC listserv and asked for veterinarians who always or never give prazosin to UO cats. And those veterinarians were eligible to be enrolled. Anybody that intermittently prescribed prazosin, those veterinarians were excluded from enrolling their patients. So they were trying to remove bias, that it was only going to use those vets that gave prazosin as an all or nothing thing. This is, I think, questionable. I I never have said, I can never say that I have never done something. And I have always forgotten to do something despite when I said that I've always done it. I don't think that we are that great. There always might be that scenario. I'm saying always. But there is very commonly that scenario that you wouldn't want to give that cat prazosin, despite the fact that you give it to everybody. Maybe you unblock them, but their blood pressure is 60 and remains that way for the next couple of hours. Maybe they're not going to get it. Or maybe you always have trouble unblocking cats, and maybe you're just not good at it. And all of your cats seem to have problems, and you give everybody prazosin because your technique is bad. So this is not a clean design. This is obviously a bias. There are reasons that those clinicians always give prazosin and those clinicians never give prazosin. Additionally, the dose of prazosin was not investigated, it was not selected, it was not controlled for. So you might have vets who give a 1/4 mg per cat once, and that's it. You could have cats that give 1 mg per cat 3 times a day, they'd be included. So it's a very dirty design in my mind. Cats were excluded if they had stones or cancer, but there's no methods of how those would be diagnosed, and it wasn't specifically stated that all cats required to have radiographs or ultrasound performed. So it sounds good, but I don't have the confidence that that was actually done. Then there was a local review of records. So the veterinarian who submits their cases, they were the ones to go through and select their cases to share their data, which, knowing that they have elected to participate in the study evaluating factors for UO in cats, I'm not accusing anybody of anything, but that provides an opportunity for someone who is very unblinded, who's searching through their medical records to say, well, you know what? This case was a really weird one. It doesn't really fit my other patients. I'm going to set that one aside. I have no evidence that that happened. I also have no confidence that it didn't happen. It's a huge variable that could be there with the way that the study is designed. But moving forward, they did identify 388 cats, the vast majority, 78%, received prazosin versus 22% that didn't. Looking at the rates of recurrence, 11% reobstructed who received prazosin versus 6 who didn't at 14 days, 24% that received prazosin versus 13% who didn't, and they state that the cumulative rate of reobstruction was higher in cats that were prescribed prazosin by 14 days. There is absolutely no p-value that is given to this. So I perform my own Fisher's exact test on this because reading their methods, it seems like that is the test that they would have done. And I came up with a p-value of 0.026, but it's not in the manuscript. It's not there. They also found that those cats that had a difficulty to unblock or a gritty urethra had a higher rate of recurrence. Maybe that's their disease. Maybe that's the skill set. Who knows? But here in this retrospective cohort study, they found that there was a higher rate of recurrence at day 14. Part 2 of the study, they try to do a meta-analysis of the minimal studies we have. And they do 2 parts. The first part is they take their study and they take the 2 prospective and the 1 retrospective study, and they compile, aggregate all the data. The second half of this, they exclude the 1 retrospective, they include the 2 prospective and their own retrospective in the analysis. Okay, so when the 4 papers were evaluated, it was a total of 700 cats. The majority, still 72%, received prazosin, 28% didn't. Recurrence was not different between groups, 20% in the prazosin, 15% that received placebo, and there was no significant difference between the groups. Again, no p-value was given. I don't know who reviewed this paper. It blows my mind and frustrates me. But remember, we have 2 retrospective studies here. We have two prospective studies that are combined. The prospective studies uses different doses. The retrospective studies neither controlled for the doses, they're all over the place. But no improvement was seen. And the second part, they eliminated the retrospective study, used the two prospective studies, again, different doses, include their retrospective study. They have less cats here, still about 73% receiving prazosin. Recurrence was seen in 24% of cats that were on prazosin, 12% that didn't receive treatment. And they said that there is a significant difference in the rates between groups, and no p-value again was given. I don't get this. I don't get how this all, to me, almost seems like data mining, like they did a big meta-analysis, no difference was shown, let's exclude a study, aha, we found a difference. I think it's just very dirty science and dirty statistics to do this. These are studies that are probably not even, should be really combined in terms of a meta-analysis because their approaches are very different, the drugs are not controlled, and I don't know why reducing the number of patients, why that is a better thing. And we're still including prospective and retrospective data. So their discussion is the results of the study failed to show a reduction in the risk of recurrent UO in cats treated with prazosin and at either evaluated time point, and in fact showed that cats prescribed prazosin were more likely to reobstruct within 14 days of hospital discharge. Again, no p-value given. Prazosin should be considered an ineffective treatment for the prevention of recurrent UO in cats, and other strategies should be considered clinically. So those were their main findings. So limitations. This is a retrospective cohort study. We all know the best study design is going to be a randomized, prospective, placebo-controlled study, and that retrospective cohorts studies have been overturned time and time again when a prospective study has been done. The evidence for that is infinite. Look at all the studies that have been done looking at cohorts of vitamin D in people. You have vitamin D and it helps everything in a cohort study. The randomized controlled studies have universally failed to show improvement of vitamin D. So study design makes a huge deal. There's also treatment bias. Why are these vets not giving prazosin? Why are they giving prazosin? Are they really giving it to everybody? Are there cats that slip through that were different? And that is not able to be captured in the way that this study was performed. The local review of records, the submitting veterinarians, they were unblinded to the objective. It again provides more opportunity for bias. There was no evaluation of other therapies such as any type of analgesia, sedation, anesthesia, any medications, no evaluation of catheter size. Do we know that all patients had stones excluded? They didn't say how they were going to be excluded or confirm that they were. So that it's a study that has more questions, I think, than answers. That second part, their mini meta-analysis, again, you're comparing different doses of prazosin. The individual studies were underpowered. They weren't the cleanest designed studies as well, too. Why would you exclude one retrospective study but keep yours? And then when I do a power calculation of all those 4 studies combined, it still is underpowered. We still only have 22% power to detect a difference. So the conclusions that I come to here, the strength of the current study, I think is weak. I don't think that this is a great study. I don't think that it changes anything. Surprisingly, after this study, you hear in my hospital, clinicians now, the interns are specifically saying like, well, we don't give prazosin now. So it seemed like this study has made some ripples, at least in my hospital, that people have stopped giving prazosin, and I don't know the numbers, but I think the majority of cats that had a UO in my hospital were probably getting prazosin for it. And that has shifted with this paper. I don't think this paper is strong enough to change what I would do. But I think the evidence for the use of prazosin for urethral obstruction is also weak at best. There's only one study showed an improvement in outcome versus phenoxybenzamine, and as I already discussed, they were different time periods, different analgesia that was provided. Could that even be effective phenoxybenzamine? Could that have had a more negative effect there? There was one study showing that the randomized addition of meloxicam had no effect. So I don't know if that had a specific role in that paper or not, but I don't think that we have a lot of evidence for prazosin just from the anatomy, the physiology, where these obstructions are happening. So many of them are there right at the tip of the penis. There is no smooth muscle that's there. And that hypothesis of, well, maybe things change after you have a catheter in place and maybe there's spasm is not unreasonable, but it's also not investigated. It's completely an exploratory hypothesis, and despite that, that is permeated into how so many people practice. So, prazosin, is it helpful or harmful in the use of feline urethral obstruction? I really don't think we have evidence that it's helpful. From the papers that have been published with all of their individual strengths and weaknesses, but is it harmful? I don't know if we have evidence that it's harmful. The current study is the one to show that there's a higher rate of recurrence, and as I think I've driven home, there are many critiques of the current paper that I have, at least. So that's what I have. I have another poll to ask people another question, but I'd love to open it up to comments, any questions, any criticisms, any other things that you want to say you thought were interesting, were confusing, were annoying. Was I completely off base? What are some thoughts anybody have?
Hey GD, this is Jennifer Delani.
Yeah.
I'm a criticalist for the group. I just figured I'd throw out there what my takeaway from the paper was. And I agree with literally everything you said. I think it's a very frustrating paper. My personal change in practices, I'm no longer chasing extremely fractious cats in the hospital around with prazosin. And we had a cat recently that was untouchably fractious. We're sedating these cats with ketamine, propofol to get like a once daily PPR. And after the cat had recovered from its sedation and never was really like flat out, it was still trying to go for the nurses. They had pilled the cat with a capsule of gabapentin and a capsule of prazosin, turned their back, turned around, and the cat was apneic and subsequently arrested. And at intubation, they found the pill pocket in the back of the cat's throat, even though they thought it was fully recovered and it had been like 10 minutes since it had gotten any drugs. And so we got the cat back and whatnot. But after that, I was like, wow, there's really no evidence to suggest maybe that this is helpful. Am I going to continue to chase these fractious cats around when maybe we're risking upper airway obstruction in them and killing them after that? And so personally, when they're fractious in the hospital, I've just stopped that because I don't think it's worth it.
No, I think, one situation like that, can really burn you for sure. I'm interested, I know, Dr. Cooper, I saw that you're on Ed. Do you have any comments, or I'd be interested to see, since you authored the controversies paper, what your practice might be, if you're so willing to share with us?
Yeah, I don't know. Are you able to hear me?
Yeah, absolutely.
Okay. Yeah, no, I think all of these papers together are interesting, and I think agreed that with the most recent retrospective, and I have to, I guess, in the interest of full disclosure, I've never been a prazosin person, and so I was somewhat happy to see the paper, and then recognizing some of the kind of limitations to the methodology and stuff like that. I do think, though, even in looking at the previous two prospectives, it's a fair point that both studies did have higher incidence of recurrence, and exactly why that would be the case is is it more stressful to try to get the pill into them? But they were placebo controlled, so that really shouldn't be a factor. And what I will say too, from the standpoint of whether or not there's urethrospasm or some functional component, we have a decent number of our block cats that when they come in are kind of standard protocol, because most of them are fractious and unfriendly, is we'll give them ACE and methadone. Let them chill in a cage, and still need to finish gathering the data and get it out there. But there's a portion of them that then pee spontaneously. And I can't come up with another good reason, and not to say that it's necessarily even the direct relaxation effects of ace-promazine, or more a little bit of the central decrease in sympathetic outflow that is a contributing factor. But we give them those drugs, and then 10, 15, 20 minutes later, they've spontaneously urinated. And, if I can't come up with another good reason other than there is some functional component. And as you stated, you definitely see those cats where, as you go to extrude them, they're just puckering away. And granted, that's the skeletal muscle component. So that says nothing for the smooth muscle. So yeah, I think there is enough evidence that prazosin isn't helpful, regardless of whether it's truly harmful, regardless of whether it increases the rate of reobstruction. It doesn't seem to do anything to decrease it. And if you need 3,000 cats to try to find a difference, most of those studies, based on the trend, would have found potentially an increased association. And so, I guess my thoughts are there's no merit to using prazosin. What is the right target? I still don't think we know. Is it benzodiazepines for that distal skeletal muscle relaxation? Is it something like ace-promazine for more the central sedation effects versus something that we haven't yet found?
Yeah, I think that those are great comments for sure. And Kathy James had posted on the chat basically the same thing. Like, do we think that maybe there's a bigger role for ACE or benzos? And it is surprising how many of those cats that you can't touch, that you just narc them down, and then 15 minutes later you look in their cage and they have a puddle of urine around them, which is great. Hopefully then they can head out. Hattie had asked, do you cysto those cats when you just give ace-promazine or opiates? Just because that might be an argument for over-distension playing a role. Good question. I'm not the one who's giving them that. I just hear about those cases. And what do you guys do? Do you guys do a decompressive cysto, or are they too fractious to touch at that point, so you're just letting them cook for a while?
Yeah, for the most part, it's just they cook. So it's not necessarily that we've done a cysto at the stage that they then spontaneously urinated.
Excellent. Well, we can certainly keep chatting and discussing the questions that we have, but let me go ahead and just launch this other poll that I have. So after going through the literature, which was actually kind of fun to go through, definitely reading through studies that I had never done before and brought myself up to speed on things that I probably should have known. But after reviewing the literature, or listening to me review it, which you can take that with whatever grain of salt you want, how would you approach the UOCAT? Do you not prescribe prazosin? I'm still not going to do it. I'm going to give prazosin more, or I used to give prazosin, but I won't give it, or I'm probably not going to give it as much. Just curious to see how is there any impact based upon today's discussion?
I don't know,
I'll,
Jay.
I'll
I was going to say this quiz kind of goes against your never saying never and never saying always. I'm having a hard time with answering it because of that.
No, that everybody always or never does something, and you have to commit to the poll, and I will hold this poll against you forever. If I ever hear that you go against the poll, I will remember.
This is it. This is it. I'm in not a unique situation, but I'm in a situation where I train residents and they're making the final decision on these interventions. And so we take this opportunity. I love blocked cats because we have this conversation that you just went through on every one of them and kind of have a chance to evaluate the literature with the student as well. And then I kind of give them the freedom to make their decision based on the evidence or lack thereof. But if I were to actually make that decision myself, I would guide towards not prescribing it. But I've prescribed a ton of it.
Right.
Yeah, I used to give prazosin for or I'd give prazosin for all block cats, and I'm a criticalist, and so I see tons of them. I did my paper for residency on block cats, and I currently work at the institution where the Hetrick study was published, and Hetrick just went down to relief a couple months ago, and so we were very much gave prazosin to every single cat, and I mean you did a great job reviewing all the literature in to me, I don't buy what they had about it making worse. That was a bunch of kind of garbage. But either way, looking at all the data, like there's no even Hetrick's study wasn't designed to look at prazosin versus nothing. It was just prazosin versus phenoxybenzamine. And so for me, when I put out my journal summaries this past month, I was like, for me, I'm don't see any benefit to using prazosin, and with such would stop using it, as well as not just because the data, but also because when you physiologically think about it, right? If there was like a physiologic reason that prazosin would be beneficial, but maybe the data wasn't quite there, I could still hold on to that. There's a solid physiologic reason, but even physiologically, there should be a benefit. Most of the obstructions are at that kind of distal tip or distal third. Um, and so for me, I'm definitely in the camp of switch to stop using it.
Yeah, I wish Dr. Lulich was on today because I feel like I just created a big like soapbox for him to stand on and to continue to expand upon his letter to the editor. And I've certainly heard him share those comments, and I don't want to put words in his mouth, but it would have certainly been interesting to get his take as well too. Well, I think this has been a great discussion, everybody. We're at the end of the hour. So I hope it was entertaining. I hope it was fun. I hope it was thought-provoking. Thanks so much for everyone for coming. Great turnout today, and love the participation. Look out for an email from me. I'll post this recording on the website for the ASVNU, and please consider signing up to present. It's fun. I've done it 3 times so far. So, you can do it. We're happy to change the time if it fits better for your schedule. It's a great thing for us to be able to continue interacting from afar. Great to see everybody. Hope you have a wonderful weekend, and I will talk to you soon. Have a good one.